Good morning, good afternoon, and good evening. It is with great pleasure that I welcome you all here today for this webinar on optoacoustic imaging in inflammatory bowel disease. I'm Dr. Tim Devling, Director of Sales and Applications at iThera Medical, and I will be moderating this session. The webinar itself will last for about 40 minutes, and we very much encourage questions. If you maximize the Go-To tool, you can see a question box where you can type them in and we'll answer them at the end. The webinar will also be recorded and will send you a link in the next few days. So I welcome our speaker today, Professor Dr. Maximilian Valder from the Medicine Department No. 1 at the University Hospital Erlangen. Max has a very strong research interest in the imaging of gastroenterological disease, and this led to his initial pilot work that successfully demonstrated the potential of MSOT to image Crohn's disease severity. This has blossomed into a number of research directions, which includes setting up the first multi-center study for IBD in the form of the Horizon 2020 EUPHORIA project. So we very much look forward to an interesting talk, and over to you, Max.
Well, thank you, Tim, for the kind introduction. And I also want to welcome all of you to this webinar series. And I'm really happy to contribute by telling you something about our research on optoacoustic imaging in inflammatory bowel diseases. So as probably many of you know, there are two main types of inflammatory bowel diseases, ulcerative colitis and Crohn's disease. Ulcerative colitis is affecting mainly the large intestine. It's starting at the very distal region, in the anorectal region, and can then go on continuously proximally up to the whole colon, whereas then Crohn's disease can affect any part of the gastrointestinal tract, such as the small intestine or the colon itself. The incidence is about 4 in 100,000 inhabitants per year for ulcerative colitis, and about 5 per 100,000 inhabitants per year in Crohn's disease. Usually the diagnosis is made at a very early age, something like between the 20 and 40 years of age, and patients are affected mostly for a long time, maybe even the whole lifetime. So this is actually kind of what the course of the disease can look like. So patients can have phases of active disease with intermittent remission. So we have certain activity flares when also high symptoms might be available, like diarrhea, abdominal pain, rectal bleeding, and maybe also complications that lead to surgery, like the development of strictures, fistulas, for instance, or even the development of colorectal cancer. Due to this chronic course of the disease, we need continuous therapy for these patients. And luckily, during kind of the last decades, there has been a lot of research and also a lot of development of new therapeutics. So we have mainly the anti-TNF antibodies, which are approved for both Crohn's and ulcerative colitis. There are several anti-TNF inhibitors available currently, and there are many other therapeutics either under development or already approved. So basically that looks quite good, but the bad thing about this situation is that not every patient responds to every therapeutics. For instance, the anti-TNF inhibitors, that we only have a response in about 2/3 of all patients, and we have no possibility to tell in advance which patient might benefit from the therapy. Because of this, there's always the discussion about how we can optimize the therapy in IBD and what is the right target to treat. So what do we need to look at to quickly decide if the patient is really profiting from the therapy? And if we would know even which parameters are relevant, we also want to know when, how, and how often we need to evaluate these parameters. For a long time, clinical scores have been used to evaluate disease activity and also monitor the response to therapy in IBD. And these clinical scores are mainly based on symptoms of patients or even also the physician's rating of the disease status. So because of this, they're very subjective and also prone to error because some patients have really severe inflammation but have nearly no symptoms, whereas other patients might have severe symptoms but don't have a lot of inflammation in the intestine. So because of this, there has been a lot of research on which methods might be superior, and the actually gold standard at the current moment is endoscopic mucosal healing. So it has been shown in several studies that the endoscopic mucosal healing, which is defined as the absence of ulcers under endoscopy, is a much better predictor of the course of disease. As you can see here on the left panel, that patients that have mucosal healing have a much more or longer sustained clinical benefit from a therapy, for instance, and also reduced need for surgery. However, this leads to the consequence that IBD patients have much more endoscopies, of course, than the normal population, and even then have much higher risk also for complications due to endoscopy, such as perforation, bleeding, and so on. So because of this, we always are searching for alternatives to endoscopy. So we want to have non-invasive techniques that really precisely tell us how much disease activity a patient has, and also if he responds to a certain therapeutic. So one point here are non-invasive imaging techniques, for instance, ultrasound, MRI, or MRI tomography, scintigraphy, or computed tomography. And basically, all these techniques are comparable regarding sensitivity and specificity to evaluate disease activity in IBD. And as physicians in internal medicine, we are mostly interested in ultrasound because it's readily available in our wards and also in our outpatient clinic, and it can provide us very quick access to the required information. There has been also a lot of research on how ultrasound can be used to assess disease activity in IBD patients. One possibility is the Limberic Score, which evaluates the thickening of the intestinal wall and also the vascularity, which is measured by color Doppler sonography. And there you can see that you can then grade disease activity from 0 to 4 based on thickening and, of course, the increase of the vascularization. However, one downside here is that especially the color Doppler sonography is not that sensitive, so we will miss patients that maybe have at least slow or low-grade activity in the gut, which might be relevant also, especially in a therapeutic context. And therefore, we thought that maybe multispectral optoacoustic tomography is here an alternative, which could help us to maybe identify, even with a higher sensitivity, changes in regional blood flow. So we started with this research several years ago when we first got our hands on a prototype clinical system from Itera Medical. And here we could use a handheld probe, which we could just use like normal ultrasound. And we investigated here with multispectral imaging the intestinal levels of hemoglobin, oxygenated total hemoglobin, deoxygenated hemoglobin, and looked at if this would maybe correlate with disease activity. So in the first series of patients, we saw that it's actually possible to really measure hemoglobin levels in the intestinal wall, even of healthy individuals. You see here on the left, the ultrasound image where a region of interest is drawn on the intestinal wall. And then in the middle panels on the right, you see then the unmixed quantification of hemoglobin, oxygenated hemoglobin, and oxygen saturation based on optoacoustic measurements. When you compare the situation in a healthy individual with a patient with active Crohn's disease, then you can see that there's a much higher signal for hemoglobin levels in the inflamed intestinal wall. And since we saw this in the first series of patients, we decided to perform a study to evaluate if MSOT or multispectral optoacoustic tomography might be able to evaluate intestinal inflammation in patients with Crohn's disease initially. So we included in this study over 100 patients, and we then correlated disease activity based on clinical scoring with the Harvey-Bedshaw index, or endoscopic scoring with the simple endoscopic score for Crohn's disease, the SES-CD, and also with the histologic scoring with an adapted Riley score. Patients were here firstly classified as either having active disease or remission, and then we differentiated in the group of active disease patients also between mild, moderate, and high activity. Here you can see the distribution of total hemoglobin in these patients. So you can see that there's a continuous increase of total hemoglobin levels in the intestinal wall from remission to low, moderate, and high disease activity. And on the right side, you see images corresponding to examples of individual patients with the individual grades of endoscopic disease activity here. Interestingly, multispectral optoacoustic tomography really showed very good diagnostic accuracy for the differentiation between remission and active disease based on endoscopy, and it was even superior than blood values like the C-reactive protein and even ultrasound based on just measurement of intestinal wall thickness or the Limberic score. So these results really showed that optoacoustic imaging can provide really highly accurate information on the disease activity status of the patient. When we then compared also the grade of disease activity, optoacoustic imaging was among the only techniques or measurements that we made that was even able to discriminate between patients with remission and low-grade activity, what is something that's extremely important also in the context of treatment monitoring. So in addition to Crohn's disease patients, we also looked at patients with ulcerative colitis. So these are unpublished data. We also compared here the MSOT data with clinical or endoscopic scoring of disease activity based on the Mayo score, also the total Mayo score, which combines endoscopic and clinical scoring. And we could also see here that there's a significant difference, especially for total hemoglobin levels between patients with remission and active disease. And in this case, it worked for both for clinical Mayo score and for the endoscopic Mayo score, in contrast to Crohn's disease, where we could only see really significant differences when we correlated optoacoustic imaging with endoscopy and not with the clinical scoring based on HBI. What really surprised us was that there are certain differences between both forms of diseases. So in ulcerative colitis, we see that there are differences or increased values for patients with active disease for single wavelength measurements of 800 and 900 nanometers excitation. And in Crohn's disease, this was also the case for 900 nanometers, which was not the case for ulcerative colitis. So you can see this also here, that in Crohn's disease, there's a continuous increase for values measured at 900 nanometers from remission to low and moderate or high disease activity, and this is not the case in ulcerative colitis. So here we first of all needed to learn that there are really disease-specific differences for these parameters that we evaluated. We cannot say at the moment what is the reason behind this. It might be related to absorption due to other molecules, not hemoglobin, could be water or even lipids or collagen. This is something under investigation, but still these data might even be helpful in later times to be able to discriminate both forms of diseases in some way. To go on with our initial data, we set up several years ago to perform a multi-center study, and we were lucky to get funding by the European Union within Horizon 2020, together with iTerra Medical, Imasonic, and Rayfos, to perform a multi-center study for clinical approval of MSOT in IBD patients. The study has just started like 2 weeks ago, so we included the first patient now, and we are now the first center in Erlangen that started. There will be 3 other centers that will then join into the study, and we hope that we can present maybe even first data at the end of the year or at the beginning of next year. Another interesting aspect is, of course, if we can evaluate complications of Crohn's disease. And one relevant complication is the development of strictures or stenosis. And this is something that's also relevant in a therapeutic relation, since the stenosis can either be treated by surgery, or if it's more acute inflammation that is inducing the stenosis due to edema formation, it might be even accessible by therapeutic or medical treatment. And that's why we are interested in also being able to discriminate acute inflammation versus fibrotic changes of the tissue due to or with an imaging approach. And since there are possibilities with MSOT to even increase the spectral range and thereby image collagen, it might be even possible to differentiate stenosis in Crohn's disease. So you see here just images from a liver ex vivo. This was a pig liver, I think, and you can see here that there's on the left side the liver without the capsule. On the right side it is with capsule, and if you image here with MSOT this part of the tissue, you see here that in the region where you have the capsule, you can identify collagen based on multispectral unmixing of wavelengths starting by 900 nanometers up to 1200 nanometers. So there's still some room left here to maybe even get more information out of MSOT in IBD patients. One aspect that has been kind of discussed a lot, and where there's current development or continuous development, is kind of the change of the parameters that we are looking at, as I also said in the beginning. And it has been, like I said initially, mostly clinical parameters have been evaluated, like the Mayo score and ulcerative colitis. And then we move to endoscopy. There are now increasingly also histologic scores that can be used to assess histologic healing also in IBD, and use this as a parameter for therapeutic monitoring. And maybe at some time it will even move on to ultrastructural healing or functional healing. This is something that's not being done at the moment, but it's under research. And therefore we also hope to maybe refine the imaging methods that we can use to even get more precise information, even maybe in vivo or during endoscopy. And also here there have been several techniques during recent years that have been developed for clinical usage. Some of them even have been already tested for maybe an use in IBD patients. For instance, Raman scattering, confocal microscopy, multiphoton microscopy, or optical coherence tomography. So most of them have a quite good resolution, but are limited due to a limited penetration depth of maybe multiphoton microscopy, something like 200 to 300 microns, in optical coherence tomography up to or below 1 millimeter. So this is definitely something something that's limiting these imaging techniques a lot when we think about Crohn's disease as a transmural inflammation, and therefore it might be interesting to have other techniques here too. And one optoacoustic based imaging technique is raster scanning optoacoustic mesoscopy, which provides us a penetration depth up to several millimeters, with still quite good resolution up to 50 microns in lateral resolution. So raster scanning optoacoustic mesoscopy is also a new technique that's based on a spherical focus detector, which allows to acquire images with an axial resolution, as I said, about with 40 microns and a lateral resolution of 10 microns. And we can then assess tissue up to a penetration depth of several millimeters. And what you can get is basically information about the vascular microstructure. So you can see here on the right side images of the skin, where you see the skin vasculature with the different layers. And this is something we also then applied to intestinal samples, and even measured intestinal or colon in vivo in murine models of colitis. And also here we could see that RSOM here is able to really discriminate between normal healthy colon and inflamed colon, just based on changes of the vascular morphology, like the diameter, for instance, and also the whole blood volume in the tissue. You can even use this technique to detect cancer. So here's an example of a murine cancer model, where you see a small polyp with just a diameter of a few millimeters. And also this is something that could be readily usable in a clinical context. Although this is quite far away at the moment, because the system that we are using at the moment is a benchtop system that cannot be used endoscopically, but we hope that the developments will move on and we can use such an approach at some time also in vivo during endoscopy. So to sum all this up, I want to say that MSOT allows the quantification of intestinal inflammation in IBD patients, that in contrast to other non-invasive techniques, MSOT allows also the detection of low-grade inflammation, which is a feature that is extremely helpful in a clinical setting. And future developments such as enhanced spectrum, MSOT, or endoscopic RSOM might provide additional information about the disease activity and about complications. And MSOT might serve as a helpful diagnostic imaging technique in inflammatory bowel diseases in future times. So many people here in Erlangen, and also in other institutes or at other sites, were involved in our studies and are also further involved. So I want to thank all of the people that are mentioned here, and I want to thank you for listening, and I'm happy to take any questions.
Thank you very much, Max. So we have some questions coming in, but if you do have something you do wish to ask Max, please type it into the question box and we'll get round to it in the next few minutes. So I'll start off with a question on the exclusion criteria. So for MSOT, are there any specific exclusion criteria? Specifically, is the technique suitable in neonates or pediatrics?
So basically, exclusion criteria are mainly, it depends on how you want to see it. So in the study that we are performing now, we have certain exclusion criteria that are based on the regulatory authorities, so also the regulatory process. So like, we cannot include females that are pregnant or that are breastfeeding, for instance. This is just something that was required since it's now within the approval process. Except from this, there are not many limitations about what could be feasible. One limitation at the moment is the penetration depth that we have. So it's about, depending on the situation, something like 2 to maybe 2.5 centimeters. So that means that in more obese patients, it might not be possible to really image the intestine in a sufficient depth. So this is something that might then lead to a failure of the measurement. Apart from this, we realized that it is not working well if you have tattoos, for instance, in the skin region where you need to apply the MSOT handheld device, because the light is absorbed then by the ink of the tattoo. And also, if you have a very dark skin, it might lead to problems with really light absorption already at the skin level. In pediatric patients, it's actually something where we don't see any problems with doing it basically, but of course also there would be a requirement for dedicated approval also for pediatric patients.
Okay. Do you see positioning of a technique like MSOT more for diagnosis or for therapeutic monitoring?
So for diagnosis, it might be problematic, because what we evaluate with MSOT is rather an unspecific phenomenon. It's just the increased kind of blood content or vascularization in the tissue, which is kind of a surrogate parameter of acute inflammation. So this might also be changed in the same way in other types of colitis, like infectious colitis, for instance. So it cannot really be used alone for diagnostic purposes. So this is something, at least that has not been shown so far, and also I would think it might not be able to show this, but it might well fit into an algorithm of diagnosis. So also in kind of our clinical routine, we do diagnosis of IBD based on several types of investigation. So it's kind of the clinical picture, the history of the patient, ultrasound, endoscopy, histology, and there MSOT might also take a part within this procedure. For us, the relevance is much more important in therapeutic monitoring, because there we need techniques that provide us a very accurate information very quickly, very well integratable into kind of the clinical workflow. At the moment, as I said in the presentation, endoscopy is regarded to be the gold standard, but of course patients will not want to have an endoscopy like every few months, and therefore we need to have alternatives to endoscopy, and there's MSOT could be something that fits into this.
Okay, thank you, Max. Going back to, I suppose this relates to the what you mentioned before about depth penetration. So two similar questions, which I'll combine into one, is have you considered the potential for false negative findings of disease activity, given Crohn's disease can manifest in bowel loops that are deeper or hidden? And a kind of similar question would be, does disease location in Crohn's disease matter in diagnosis?
Yeah, so these 2 points are extremely good questions, and they are also, they point to a critical aspect. So basically, we are not able really to evaluate the whole intestine. So we can, due to the kind of limited penetration depth, we are also limited to certain regions of the intestine. So in Crohn's disease, of course, the most patients have disease activity either in the terminal ileum or in the sigmoid region. So these patients we can, or these regions we can evaluate quite well. But as soon as, for instance, there is only focal inflammation in some parts of the small intestine, we would miss them probably. So that's why also there is a certain limitation for really doing the diagnosis and even evaluating the extent of disease. So it might be much more better suitable for kind of just comparing disease activity in a known region where we already have proven that there is inflammation during the course of disease and maybe after starting a new form of treatment.
Okay, two interesting technical questions is, just to clarify, you mentioned you can detect collagen. This is an indicator of fibrosis, so you can detect fibrosis, yes or no?
We don't know it yet. So this is something we are currently investigating. So there has been a study from Ferdinand Knieling's lab and Adrian Regensburger, where they have looked at muscle dystrophy in pediatric patients, and there was a quite well correlation between the collagen content in muscles and also MSOT signals for spectral unmixing of collagen. So we are quite sure that it works to evaluate really the collagen content inside also of the intestine. But then, of course, the question is, can we really kind of discriminate that from patients where there is more acute inflammation in a strictured region, or if there's more fibrosis? This is really something we don't know yet. We are currently investigating this question, and we would be quite happy if it works, but this is kind of really basic research that's ongoing.
Brilliant. And just an interesting question actually is, would the MSOT signal change in anemia? And I guess it would.
Yeah, so we tested this. So in the study in Crohn's disease, where we evaluated over 100 patients, we also had systemic hemoglobin levels for each patient. And in Crohn's disease, there are always some patients that have low-level anemia, so they kind of also have either problems with uptake of iron, or even they lose red blood cells due to the inflammation in the intestine. And so there's quite a relevant variation of hemoglobin levels in the blood among Crohn's disease patients. Interestingly, there was no correlation between the MSOT parameters in the intestine and the systemic hemoglobin levels that we found with normal lab testing. So we would say that if there's an influence, there must maybe be a very dramatic change of systemic hemoglobin levels, because normal variations and the levels that we had were from, I think, something like 7 to maybe 14 grams per deciliter. So even in this range, there was no direct correlation between the systemic hemoglobin levels and the local hemoglobin levels in the intestine.
Interesting. So a few questions have come in related to ultrasound, so I'll try and combine them into one. And it is the technique similar in practicalities to ultrasound scanning? How do you think a technique like MSOT compares to ultrasound? And kind of the final part to that is, how does MSOT compare to a technique like contrast-enhanced ultrasound?
So to the first question, so from a practical point of view, MSOT perfectly integrates into conventional ultrasound. So the procedure is performed nearly in the same way. The only difference is that you need to wear safety goggles because of the laser that is integrated into the system. But the workflow is kind of quite used to anyone who's experienced with performing intestinal ultrasound. So in this regard, also, I would envision to maybe in several years have ultrasound systems with an integrated MSOT. So like we kind of just switch on a button to have color Doppler or elastography. In a similar way, we maybe at some time can switch on MSOT and then look at optoacoustic signals. this would definitely make sense, because also in MSOT, which we performed, we always used kind of the multimodal approach with combined with ultrasound to initially identify the relevant structures and then measure MSOT in these structures and quantify the signal. So definitely, I think that these technologies belong together. And to the second question with contrast-enhanced ultrasound, basically, I think the difference is a little bit that with contrast-enhanced ultrasound, of course, we have the possibility also to evaluate dynamic parameters like kind of the wash in, wash out of the contrast agent, which also have been shown to provide some information on the treatment monitoring in IBD. But just kind of the normal vascularization that we see with contrast-enhanced ultrasound is, I think, not comparable to MSOT, because the quantification of the signal intensity is not possible in the same way, and this is something that we really rely on. So maybe MSOT is providing a similar information as dynamic contrast-enhanced ultrasound can provide, just a lot more easier, because with the dynamic contrast-enhanced ultrasound, you need to evaluate then the curves of the wash in, wash out of the contrast agent, which is at least to what I have been seeing here, a little bit more time consuming, and here we can just maybe draw the ROI and get our signal. So this is maybe a little bit more practically for a clinical workflow.
Okay, so thank you very much, Max. There's a few more questions which I will, I think we'll address those individually because they're quite technical. So we'll follow up with those one-to-one. I would say, Max, thank you for a very interesting talk and to show the kind of emerging data that you're generating. Thank you all for attending today. As mentioned, we will send the webinar link so you can view this in your own time. And again, I'll just say, really nice talk, Max. Thank you very much.
Thank you, Tim, and thank you to all listeners.